right. Got it.
All right, do me a favor, text me the contact information, I'll give her a call. Yeah, I don't know if Abby's gonna want to use her. But we'll see. At least I've got the information. How you doing otherwise, buddy?
I'm doing just fine. I
Can
can't
you
get
hear
Zoom
me?
on my computer for the first time.
Can you hear
So-
me?
Yeah,
Yeah,
Okay, just making sure. All right.
okay, so you got in. So the passcode I sent you worked.
Yep.
Good. I'm just having trouble getting it on the phone. So who cares? All right. Let's go ahead and welcome everybody this evening.
Welcome. Thank you.
Sure appreciate everybody stopping in.
Mhm.
Tiffy and is Alexandria here also?
She's not on us yet. We're still waiting on her.
All right, we can move on. Maybe there's a slight glitch in her schedule. So, but I wanted to open up this evening's Zoom with on a positive note, like we always do, and we have a friend of ours from Philadelphia, Robin Hinton. She's a minister, and she's going to open the Zoom today with a positive note, a message for the diabetic population, not only of the Caribbean, but of the world, and see if we can reduce these amputations by 50% in 5 years. And so, Robin.
Okay. And, thank you, Dr. Vic, because I find it just really a pleasure, because I've been in, and the times that I was unable to be on live, I did watch the recordings, and it's wonderful what's happening here. And it's very encouraging how everyone is getting together and looking at the people in the field. So I just wanted to express today, just in a message, just to say how grateful it is to see the collaboration and new resources coming together, the partnerships that you're making, the synergies that are happening. And I also want to say that for the community, thank you for healthcare professionals who really care, who honestly and sincerely care, as you all are coming together on behalf of the diabetes community. But we have hope, because there is healing, because an additional focus, this education, because we know knowledge is power. So what you're doing is providing opportunity for people to get more awareness through this technology. And we are just hoping and praying for increased health literacy and an understanding of how people can self-manage and how they can make better decisions regarding diabetes and the footwear they use and everything. So we put out prayers for those who we know need encouragement, those amputees, those where amputation is looming. Prayers for families and their caregivers who continue to supply their need. And we know that there is a source where it's unlimited. So we are really calling for God to bring us the resources that are needed, the financial, the emotional, the all the awareness that's necessary. So right now, I'm just standing in agreement with all of us that you're undergirded, because you have a steadfast advocacy for equitable health care, for emotional care, mental and spiritual care that goes along with this. It's a complex environment. It's a complex situation based on a healthcare need. So we are grateful, though, that there is a change that we see through these Zoom sessions where people are getting awareness. I'm getting awareness of things I didn't know before. So I'm just grateful that we can come together and even put out where we can for social justice issues where there's unjust advocacy or unjust accessibility for people who need medical care with diabetes. So we just know, and we're going to stand together and hope together that all the people, that all of the resources are rallied around the world for this issue, that there's a new awakening. And we know that with faith and hope, we can stand and declare for what's to come. So God bless you for what you're doing. And we are just excited. I'm excited to see what's going to come out of this and what you're doing.
Excellent. Excellent. Thank you so much, Pastor Robin. I know you lost a brother to diabetes, our cousin Ron Ski, and he unfortunately had an amputation or two, and it led to his ultimate demise. And he falls right into the statistic of what we're trying to prevent.
Yes, that's true.
So it's good for us to call on you this evening to join us and to open up the Zoom meeting. So once again, thank you very much, and hopefully you'll stay with us and enjoy the rest of this meeting this evening. Everyone else who is with us, once again, appreciate it. We wanted to start off the lecture series after our opening with the president of the International Minimally Invasive Foot and Ankle Surgery, or foot and ankle surgeons, in fact. And she's leading the way right after COVID to start having seminars again where people can get together in a setting and study medicine face to face or mask to mask without having to do everything over the Zoom like study medicine. And so some things you just need hands-on skill, and Beth, the president, Dr. Claywitter, has the key when they get their Zooms. Okay. Are you able to get that screen back up, Dr. Claywitter?
Do you guys see my screen?
No, not yet. We saw it earlier.
I can
I
see
see
it.
it.
Yes,
I
I
see
do.
it. Yep.
Oh, let me
You can
move
just
my
hit
phone.
play.
Very good. I got
There it is. Thank you.
okay.
Yeah, so you have the floor.
Okay.
You have the Zoom.
This is a pre-recorded lecture, so I'm just going to go ahead and play it, and then if there's any questions at the end, I guess we can talk about them. If I can get to it again. Okay, where are you? There you go. Okay.
And while you're doing that, Dr. Claywitter, I was just reminded by our host, one of our hostesses with the mostesses,
Elizabeth Claywitter.
that we're going to ask everyone,
Sorry, I'm
I
pausing
believe,
you.
Tiffany, is it to mute themselves and cut their video off? How does that work, Tiffany?
Hi, everyone. Good evening. So here are just a few housekeeping rules. What we would like for you to do is whenever you come into the room, keep your mics muted and only unmute whenever you're speaking. And as much as we love to see your beautiful faces, we would also ask that if you are not speaking, that your camera should also be off and only turned on for a photo op, or like I said, whenever you're speaking. Thank you so much for your attention and enjoy the presentation.
All right. All right, Doctor.
Okay, I'm gonna.
Claywitter.
My presentation today will be on a diabetic ulcer case study using the minimal incision talus bunionectomy procedure. I am currently the president of the Academy of Minimally Invasive Foot and Ankle Surgery, a fellow of the Academy of Minimally Invasive Foot and Ankle Surgery, and I'm also board certified in minimally invasive foot and ankle surgery by the American Board of Multiple Specialties and Podiatry. The patient's history: he is an 81-year-old male. He is neuropathic, ischemic changes, his pulses are 1/4, and he has severe pitting edema bilaterally. Patient typically wears compression hose for his edema. His blood sugars are usually below 200. Patient has difficulty ambulating and requires a walker for assistance. His daughter is his caregiver, and she typically brings him in for routine care every 2 to 3 months. First presentation of the patient was September 2012. Patient presented with a callus sub-right fifth metatarsal head. Typical treatments for callus is debridement, offloading, and diabetic shoes. December 10th, 2012. Patient presented with a superficial ulcer sub-right fifth metatarsal head. The ulcer was stage 1, measuring roughly 1 by 1 centimeters, with no cardinal signs of infection. His blood sugars were within normal limits. Treatment that day included debridement, offloading, and a surgical shoe. We also discussed minimal incision Taylor's bunionectomy, but his daughter declined at this time due to her father's age and health. He was in to see his primary care physician the week before and was put on antibiotics due to his ulcer. The patient followed up with my office December 13th, December 27th, and January 10th of 2013 for ulcer debridement. Patient's daughter informed the office that he would be moving to assisted living and would no longer be coming in for care. There is a podiatrist on staff there that performed nail and callus debridement. September 5th, 2013, the patient returned 8 months later to the office with stage 2 ulcers, sub-right fifth metatarsal head, with no cardinal signs of infection at that time. There was no change in his neurovascular status, and his blood sugar was 255. Patient history since our last visit. The patient had not been controlled. He had numerous hospital visits due to cellulitis in his right leg. He was not wearing his diabetic shoes with accommodative inserts when he presented to the office. He had been treated by another physician while in the hospital. The patient's primary care physician called my office and let me know that he believed that the chronic cellulitis in his patient's right leg and the uncontrolled blood sugars were due to his ulcer. And he admitted that he needed to be in and have surgery done as soon as possible. Treatment that day was discussed and scheduled incision Taylor's bunionectomy for October 8, 2013. Sent the patient out for an arterial Doppler, and he was cleared by vascular for the surgery. I debrided the ulcer, offloaded it, and he was put into a surgical shoe until the day of the surgery. October 8, 2013, the patient was scheduled for a right Taylor's bunionectomy. The patient denied any nausea, vomiting, chills, or fever that day. Surgery was canceled due to cellulitis in his right lower extremity and a malodor from the right foot. A prescription for Keflex was dispensed, and he was scheduled to follow up with me the next day. October 9, 2013, the patient presented with nausea, chills, and a fever of 37.8 degrees Celsius or 100 degrees Fahrenheit. His blood sugar was 250, which was high for him. I called his primary care physician and let him know. The primary care physician then told us which emergency room he wanted us to send the patient. On October 10, 2013, I spoke to his infectious disease doctor's nurse. The patient was admitted the day before and was put on IV antibiotics. They wanted copies of his treatment records, which were promptly sent over. October 14, 2013, the patient was discharged from the hospital. Prior to being discharged, a bone scan was performed on his right foot to rule out osteomyelitis. On October 24, 2013, the patient was cleared for surgery from his infectious disease physician, and due to the fact that he knew that I performed minimal incision surgery, he considered this procedure safe for the patient. October 28, 2013, the patient was cleared for surgery by his primary physician. November 4, 2013, minimal incision right Taylor's bunionectomy was performed. Postoperatively, there were 10 visits from November 4, 2013 to February 17, 2014. The patient was not admitted to the hospital at all during that time for cellulitis or for uncontrolled blood sugars. The picture on the left shows the ulcer during the presentation in September 2013. The picture on the right was the picture taken in February of 2014. You can see that it's cleared up and the edema on the lateral aspect has resolved. The x-ray on the right were taken December 10th, 2012. I typically take three views by lateral of my diabetics for baseline x-rays. And you can see that there was no edema, but there is a marker, subfifth metatarsal head. The x-ray on the right was taken September 5th, 2013. You can see significant edema, tissue swelling, and then subfifth metatarsal head. The x-ray on the left was taken immediately after the surgery on November 8, 2013. The reason that the osteotomy was a little bit more proximal is I wanted to stay away from the ulcerative site. The x-ray on the right was taken October 13, 2014 for a final x-ray. During the intervals between the initial surgery and a year later, the patient was following up every 2 to 3 months for routine care. Conclusion, minimal incision surgery is a safe and effective surgical technique in patients with comorbidities.
I typically do a lot of those talar bunionectomies in my office, and I find them to be fairly safe for them. And as you notice on the final post-op, the fracture site never did completely resolve. He was neuropathic and he had no pain at all. The whole point of that was to resolve the ulcer. Now, if his daughter at the very beginning of all of this had decided that his father wasn't too old, he would not have had to go through a whole year of this. And I find that a lot with my patients, the kids, their children come in, well, they're too old. And I'm a little bit more stern about those kind of patients' kids now, because it doesn't matter how old someone is, if they are hurting, that needs to be addressed. So, I do deal with my diabetics a lot differently now. I'm a little bit more aggressive in fixing the problems instead of waiting. Does anybody have any questions?
So he's completely healed.
Yep.
Okay. And is it non-union you were saying, or is just will take a little longer for the bone to complete its union?
I didn't take any more x-rays after a year. And there was no movement at the fracture site. There was no erythema, no issues. Like I said, he had neuropathy. And I was pretty happy that it turned out the way it did. The guy was obese. He had elephantitis. And I was thrilled. His doctors were all very thrilled. I get a lot of referrals from vascular people because of the type of procedures that I do.
And what the common factor, which is polyneuropathies for so many ulcers and amputations, how were you able to address the neuropathic foot and the polyneuropathies that were present?
He was in his 80s. I didn't really address the neuropathy with him.
Right.
He wasn't having any issues with any of that. He had severe pitting edema. I mean, that actually, I feel, is a big contributor towards a lot of the neuropathy. I just dealt with what the problem was. He didn't have any pain with that at all. It's just that he was sick all the time.
Right. Okay. Just was checking on that. Are there any other questions for Dr. Claywitter and her minimally invasive Taylor's bunionectomy? And how big was your incision for you to cut the bone to heal the foot?
Less than 1/4 inch. There were no sutures.
Less than 1/4 inch incision. You were able to surgically cut the bone and put it in a better position to take the pressure off for healing. That sounds fantastic. Well, keep up the good work, Dr. Claywitter. I sure appreciate that. And we're going to move on to our next speaker. And if there's any questions in the chat room that come up, Tiffany, I appreciate if you check it out. I can't figure out how to do it on this phone because my computer's not.
Not a
cooperating.
problem.
All right.
Sorry. There we go.
All right. And so next, Dr. Richard Mann I've tried to work that segue, if you noticed, Rich, with the polyneuropathies.
I was very,
And
very
education.
impressed.
Oh, man, what can I
Well
say?
done. Hello, Beth. I guess I'm going to meet you today as opposed to in a couple of weeks, right? Nice presentation. Thank you very much.
Right.
You have to excuse me. I got to pull up my presentation. I didn't think I would be speaking at so quickly, but here it is.
Okay. Matter of fact, I'm trying to take my time this evening. I had a little lecture to give, but I'm gonna take this computer and bang it up against the wall a couple of times. Maybe that'll help.
Okay. Can you see me? Can you, do I have my screen?
I
Can
see.
everybody see my presentation?
We can see you, but not the presentation.
Okay, how do I get you to see my screen?
Go to the
Share
bottom.
screen?
Yeah, share screen.
Let's try that. How's that?
Oh, very
Okay,
good.
you're
You can
good to
see
go.
it?
Yes, good to go.
Okay, generally I keep these, first off, thank you, Victor, and all the other people involved with the Bahamian Podiatric Medical Association. Generally, I keep these things completely non-commercial, but I think because we're introducing the remedy and Victor's helping me with that into the Bahamas, I was asked to speak about the remedy specifically, the main ingredient in it being a benfotiamine, and I'm going to talk rather briefly because I've given this presentation a number of times. I'm going to talk rather briefly about the use of Neramide to improve the symptoms of peripheral neuropathy associated with diabetes or chronic alcohol abuse. You could also have pre-diabetes on this slide as well. And thus an excellent segue, Victor, worthy of the best promoter
All
of
right.
such presentations.
All right.
So let's see what we have here. Okay, first, my financial interest disclosure. I'm the Chief Scientific Officer and CEO of Realm Labs. We make Neramide. It's a product line with benfotiamine products used for peripheral neuropathy. It's available in the Bahamas, and Victor is helping me with that. So if you have any questions specific about getting the product, you'd ask Victor. And also, if you have any questions about the presentation, feel free to ask me. Or if I'm not available, you could ask Victor. He's expert on this stuff. And that's the product that we have. So the first thing I'd like to mention is that diabetics and people who have a history of alcohol use disorder are the most common causes of peripheral neuropathy. There are 150 different causes of peripheral neuropathy, and that's probably a conservative estimate. And when someone with peripheral neuropathy walks into your office, because diabetes, for example, is a diagnosis of exclusion, it's very, very difficult to work up people unless you're a trained neurologist specializing in peripheral neuropathy. But from a practical perspective, as patients walk into your office and you want to deliver the best care you can, keep in mind that well over 50% of the people walking into your office, and I think this is true in the US and maybe even to a greater degree in the Bahamas, are either diabetic, pre-diabetic, or have abused alcohol significantly in the past to the point where they've damaged their nerves. The good news is that all of these conditions, these three major causes of peripheral neuropathy, respond to very strong vitamin B1 supplementation because these people tend to be vitamin B1 deficient, and B1 deficiency causes neuropathy. And diabetics specifically are known to suffer from both vitamin B1 and B12 deficiency. Chronic alcohol use is a well-established cause of vitamin B1 deficiency. So thiamine and vitamin B12 deficiency are well-established causes of peripheral neuropathy. And the type of peripheral neuropathy that we're talking about is best described as a polyneuropathy. It starts distally at the tips of the toes, both great toes, and it ascends up the foot and legs in the same manner in which you would put a stocking on. So first it's the toes, then it's the middle of the foot, then the heel, then the ankle, and then going up. It's called a stocking and glove distribution because if it goes high enough, it starts affecting the fingers as well. And this is a very, very common presentation, and it's length dependent. And you can think about it as a dying back phenomenon. The nerves, the longest nerves, are the toughest to support from an energy perspective. And when there's a problem with energy, they're the ones that are affected first. So the deficit goes up the feet and legs in this length-dependent stocking and glove distribution. Some people call it a dying back phenomenon. To make matters worse, especially for diabetics, is the most common drug used in the treatment of diabetes is metformin. It's I think the 7th biggest drug in America. And it's an excellent drug. The only problem is that it inhibits the absorption of vitamin B12 and vitamin B1 from the gut. And as a result, these people, the diabetics who tend to be B1 and B12 deficient, in order to have their diabetes under control, they are taking a medicine that works brilliantly in regulating their blood sugar, but it also has problems with respect to absorption of these same vitamins that they tend to be deficient in. And reversing these deficiencies is proven to be a powerful tool in the treatment of both diabetic and alcoholic peripheral neuropathy. And it's also proven to be a great tool in the treatment of pre-diabetic neuropathy, because if you remember, we spoke about this before, pre-diabetes is just a prodrome of diabetes. It's a continuation of defective glucose metabolism. And although we don't medicate you until you reach that one threshold that above which you're considered a diabetic, these pathological processes, especially to the nerves, are going on. As a matter of fact, some literature shows that there are more pre-diabetics with peripheral neuropathy than diabetics, which is really interesting. And what's even of greater interest is people just don't know about it. Doctors don't know about it. 40% of peripheral neuropathies that are diagnosed as idiopathic, in other words, I don't know why you have it, we'll call it idiopathic, they tend to be pre-diabetes. And 90% of people with pre-diabetes don't know they're pre-diabetic. So how do you reverse vitamin B1 deficiency? Well, it would be nice if it was as easy as just going into any store and getting some vitamin B1 or eating foods that are rich in vitamin B1. But absorption of B1 as you get older and as you're a diabetic, et cetera, and also alcoholism, it impairs the ability of your body to absorb vitamin B1. And that's because it's a water-soluble vitamin, and thiamine transporters are involved, and there's a limit to how much thiamine transporters can do, how much thiamine you can transport with these transporters. So we tend to use a product called benfotiamine, which is a lipid-soluble form of B1, as opposed to the more naturally occurring or more commonly occurring form of vitamin B1, which is water-soluble. And the advantage of lipid solubility is it doesn't need thiamine transporters for absorption. You can absorb the thiamine by passive diffusion. So you take it and it just diffuses in, because the gut is considered to be lipophilic, so any fat-soluble vitamins will just absorb in. What's good about benfotiamine is it's converted immediately to the water-soluble form of B1 after it's absorbed. You don't have any toxicity, which is often associated with fat-soluble vitamins. It's a strong antioxidant, it's a strong anti-inflammatory. It's been shown to block complication-causing pathways associated with diabetes. And although we're only talking about feet, these pathways also affect your kidneys and your vasculature and your eyes. Retinopathy is very common. Very, very strong and high safety profile. This has been around for 60 years, and there's just no complications of significance that are associated with the product. It's been studied extensively in the scientific literature. I think the most significant study for our purposes is this one that was done in Germany a while back. It looked at benfotiamine and diabetic polyneuropathy. Now remember, polyneuropathy is a type of peripheral neuropathy that is distributed in this stocking glove distribution like we spoke about before. And it has all the right things. It's a double-blind, randomized, clinical controlled study. And I think what's significant is if you take a look at this after 6 weeks, and that's the solid black bar, you'll see that pain is decreased, but very significantly, numbness is decreased. If you remember the case we just heard about, the patient was numb. Numbness is the leading cause of ulcerations and amputations in the feet. Neuropathy causes you not to feel the problem. So anything that can restore sensation is very, very important. And you can see in this, this study, within 6 weeks' time, there was significant restoration in sensation. That doesn't mean that sensation went back to normal. It does mean that there was a significant improvement in sensation. And practitioners who use this product see it all the time. I'm going to tell a real quick story about a patient I had who had terrible neuropathy. They came into me, had a big hole in their big toe. And I asked him what happened, and he said he went to an airport screening device, and he took his shoes off, took the keys out of his pocket, and put them in his shoes. Then after he went through the screening device, he put his shoes back on. And they had the keys were still in the shoes, but he was so numb he didn't feel it. So when he took his shoes off when he got home, he realized there was a lot of blood there. And this is not an uncommon occurrence. You always should check your shoes, make sure there are no foreign objects in there, but that's another lecture. Be very careful about how you treat your feet and where you put your feet. So we put him on this product benfotiamine, and 6 months later he came into me and he, with a big smile. Well, first off, thank God we were able to heal his wound, which was wonderful. And then 6 months later, after being on benfotiamine, which is the key ingredient in the remedy, he came into me and he told me with a big smile that today he put his shoe on and he felt something in there, and there was a penny inside his shoe, which he took out. So of course, being a doctor, I yelled at him for not checking the insides of his shoe beforehand. But the point here is that he developed sensation such that he prevented a subsequent ulceration. And vitamin B12 deficiency is a well-known cause of peripheral neuropathy. It presents many ways, but primarily it's a polyneuropathy as well. It turns out that 1 in 5 type 2 diabetics are vitamin B12 deficient. I have studies which you're welcome to. I put this up only because we'll be distributing the video, but you're welcome to call me or Victor if you want any of these specific studies. We're happy to get them to you. And how do you reverse B12 deficiency? You reverse B1 deficiency with benfotiamine. It's the most successful way of doing it. And B12 deficiency is you can get either injections. Most practitioners inject a milligram a month into their patients, but just as successful as oral vitamin B12, and the best type of vitamin B12 orally is methylcobalamin. So in summary, vitamin B1 and B12 deficiencies are prevalent in patients with diabetic peripheral neuropathy. Vitamin B1 deficiency is prevalent in patients with alcohol peripheral neuropathy. And keep in mind, when you're looking at someone with an alcoholic peripheral neuropathy, it's not how much they're currently drinking, it's their lifetime alcohol usage. Not uncommon to have patients who say, I haven't had a drink in 2 years, but they used to be alcoholics, and their peripheral neuropathy is an alcohol use disorder neuropathy. It's just as if they were drinking actively at this point because they've done some damage to the transporter molecules in the nerves. The alcohol is toxic to the nerves, and they respond very well to restoration of vitamin B1 levels. Of course, you can measure B1 levels if you want to, but the reversal of, first off, it's completely safe to give them vitamin B1. You can't overdose on that, or B12 for that matter, within limits. And it's much more rapid to start them on it and see if they did better. And then you can look back and say, well, you were B1 deficient or B12 deficient if they improved. Probably a better way of handling this clinically. Reversing those deficiencies has been shown to rapidly and safely improve neuropathic symptoms. And the remedy reverses B1 and B12 deficiencies rapidly and safely, with most patients experience improvement within 30 days. The reason it takes 30 days is that's how long it takes to reverse B1 deficiency. And if you stop taking the pills, if you've gotten better and you stop taking the pills, your neuropathy will come back probably within 2 months, because that's how long it takes for you to deplete the B1 that's in your system. We're not doing anything to fix the causes of your B1 deficiency, which in general with diabetics is they urinate it out, and in alcoholics, they don't absorb vitamin B1 well. That's also the case in elderly people and diabetics. So we're not fixing the reason for the B1 deficiency and the subsequent peripheral neuropathy, we're just restoring B1 levels. So if you stop taking the pills, you'll go back into a B1 deficiency state. There are 3 different types of Naremedy that you can get. I'll leave that to Victor to explain to you if you're interested in it, or you're welcome to call me. And if you have any questions, you can email me, come to our website, or give me a call. I'm always available to be there. Happy to speak with you. And I don't know, let's see, how do I get out of this? So I always have this fear that I've been talking to nobody. So, no one said anything for the past 10 minutes but me. So if you heard what I said and I wasn't talking to nobody, please ask me a question.
Okay. Oh, yeah, we have a new policy, Rich, that everyone mute themselves and cut the video off. And I don't know if that helps with the recording, but I know it certainly helps with the background noise. We've heard babies crying and dogs barking. And we had that all the background noise has been eliminated. But the chat room is open, and we encourage people to go to the chat room. I see Dr. Charles Perry was asking about how much progress is being made, let's say in the past 5 years, to reduce amputation rates. And if you could comment on that, I don't think anything is being done, even though everybody's doing something. The rate continues to go up.
Well, the problem, diabetes is expanding exponentially.
Right.
So you would expect rates to go up in parallel with that, and which is even a greater reason for you to be much more aggressive in the practice with respect to people with neuropathy and trying to reverse neuropathic symptoms. I think unfortunately we're still losing this battle.
Correct. That's one thing about this particular Zoom, and that you're on, Dr. Perry's on, got people from all around. But one thing for sure is we're preaching to the choir. I felt there's a defoot, and there's various experts getting on Zoom and giving lectures, but everyone's preaching and lecturing to the experts. We want to try to get to the people if we can. And if we can get to the people and stop the most common cause, which is peripheral neuropathy or nerve damage as a result of vitamin B deficiency, then maybe we can begin to find the tipping point that Malcolm Gladwell was talking about. And we can reach that point where there's no longer 982 amputations per 100,000 people like it is in the Caribbean. In the United States, per 100,000 people, it's 570. And in Brazil, it's 187 per 100,000 people. So I'm not sure what they're doing in Brazil, but we need to get some of that going. And also with the type 1, does type 1 plus type 2 diabetes, does that lead to type 3 diabetes or pre-diabetes? Why is it like a raging forest fire? Why can't the medical doctors stop the alarming increase in diabetic patients? Or can the medical doctors only treat what they see, try to lower the, why can't someone go out and just stop the cause, which is obesity, which is metabolic syndrome, et cetera? So I wonder why we're losing the battle. Maybe it's like the war on drugs for the United States. Everything there's been a war on has been unsuccessful. So we're seeing if we can reverse that with this Zoom presentation. But I didn't get any other notices from our chat room, Rich.
Okay,
So,
I just want to mention a couple of things, if you don't mind. One is you mentioned type 3 diabetes. That's considered Alzheimer's disease now.
Okay.
And there's a lot of evidence that vitamin B1 problems are associated with Alzheimer's disease. That doesn't mean if you give somebody vitamin B1, they won't have Alzheimer's disease, but it does indicate that there's an association, and that makes a lot of sense because you're talking about neurons in the brain, the central nervous system responding well to supplementation with vitamin B1, as opposed to what we're getting in peripheral neuropathy. A peripheral nerve is very similar to a central nerve. Both of them need a lot of energy, which is what vitamin B1 is. One of the actions of vitamin B1. And then you talked about prediabetes, and yeah, it's a continuum. It's an ongoing catastrophe, a slowly moving catastrophe, which should be addressed as soon as it's identified.
Can someone have type 3 diabetes without having type 1 and 2 or pre-diabetes? And in mastering diabetes, they talk about diabetes 1.5.
Well, you know, I'm not so sure about diabetes 1.5. It doesn't sound like something I ever heard, but type 3 diabetes is Alzheimer's, and Alzheimer's is very common. It's much more common in people with diabetes. And that's because the vitamin, there are a number of things going on there, but one of them is vitamin B1 processing issues.
Okay, excellent. Well, thank you for that information. We really appreciate you always joining us and helping individuals to understand the fact that you can't just treat the symptoms of polyneuropathies, of peripheral neuropathies. You actually have to treat the nerve with a nerve vitamin. And that nerve vitamin is Nuremedy, and there's maybe one or two others around, but for sure, Nuremedy works, and it can help reverse polyneuropathies, which is one of the most common factors in amputations, diabetic amputations.
Thank you very much, Victor.
Yes, sir, Rich. Appreciate you joining us. Have a good evening.
You too. Thank you for having me.
All right. And next, and looks like finally, we're going to be hearing from the Vice President of the International Minimally Invasive Foot and Ankle Surgeons. It's Dr. Beth Pires. And she is going to share with us some of her insight on minimally invasive surgery to correct various foot deformities like hammer toes, hallux malleus, bunions, and metatarsal problems. So Dr. Pierce, are you available?
I am indeed. Thank you so much. In just a second, I'll share my screen. But before I do, I want to say thank you for everyone who's taken the time to join us. I have big shoes to fill after Dr. Claywitter and Dr. Mann, and I appreciate in advance everyone's time. Let me just see if my screen will share. Let's see. And hang on one second.
It's developing quite nicely.
Here we go. Can everyone see that now?
Oh, geriatrics. Is this lecture specifically for me?
This was the lecture for everyone.
Okay, I thought because I was a senior citizen.
Oh, you funny. I'm like, oh, you caught me on that. That was funny. Don't tell anybody. I have a little bit of brain fog still. So I'll run with it. Yes, okay. It's definitely for the over 55 crowd. Absolutely.
Thank you. All right.
Everyone, go ahead, please.
Oh, go ahead. I'm sorry. I'm just running my mouth.
Right ahead. I so appreciate you having me. Everyone, this presentation is generally directed towards geriatrics and all those who have risk of more traditional surgery. I will speak a little bit more about myself towards the end, but the goal of this is to explain to my colleagues and those listening and interested, how minimally invasive foot surgery can correct painful deformities while using only local anesthesia for our high-risk group, while these patients remain ambulatory, which is a real goal, particularly as you heard about Dr. Claywitter's case. And I think it's so important to acknowledge that the tide has really changed and that minimally invasive foot and ankle surgery is now becoming of age. More and more people are acknowledging that it is safe and effective. In fact, the American Orthopedic Foot and Ankle Society in 2020 designated MIS as a technique through very small incisions that has reduced post-operative opioid use, pain, and faster recovery time with smaller scars and very acceptable results. Again, specifically with respect to geriatrics, it is a branch of medicine that deals with the problems of diseases of old age. Certainly diabetes is more likely to occur in older age, but equally it's becoming more of a problematic in younger people as well. And it is important because of the comorbidities that are associated with people who have diabetes, particularly with their older age. In terms of elder care in its specifics, and forgive me, this is more of a North American Census Bureau of the US, that by 2050, 1 in 5 will be over the age of 65. And I bet we could extrapolate it to the Bahamas, that you will have proportionate growth in your population. Of course, older patients generally have a higher rate of diabetes, heart disease, hypertension, stroke, and other neurologic disorders. In general, this group will often benefit from smaller incision sites and specifically from the kind of correction that MIS provides. We all know that general anesthesia, putting someone completely to sleep, has a risk of heart attack, stroke, lung infection, and more concerning cognitive dysfunction. It's of course greater in people who are smokers, people who have diabetes with small vessel disease, and people who are generally overweight. Leaving us with the safest type of anesthesia for these kinds of procedures, which is local, and we just inject a small amount of medicine right where the procedure is being performed. If it's just a toe, then that's the only part of the body that goes to sleep. My presentation is rather geared towards the lay population so that they can understand some of the values that minimally invasive surgery can provide. And of course, goal number 1 is to be able to wear a shoe. This woman was a 68-year-old female. She had had multiple bunion corrections, unfortunately leaving her with this cocked up hallux, almost a hammer toe, and she could not wear a shoe. But ultimately through MIS, and this is at the 1-month point, she was able to put her shoe back on. And that was most exciting for her. Here is a pre-op x-ray of just showing how severe that deformity was. This is also pre-op. You can see she's had multiple procedures and hardware. And then this is just an oblique view. If you can see my cursor, I'm going to show you where the minimally invasive osteotomies were placed, along with some pretty aggressive soft tissue correction that allowed that toe to return to a position that she was able to put a shoe on. Again, the goal can be very simple for these folks, just to wear a shoe. This was a 78-year-old female who had a fractured dislocation of her little toe. And whenever she tried to put a shoe on, it would get caught and it would be painful because of that laterally positioned aspect. And this is immediately after probably the stitches came out. So I would say this is at a 10-day point where the toe is corrected. This is the before X-ray and the after X-ray showing where the osteotomies were here and there. And the patient was really very happy with that. Notice on my prior film picture, there are some steri-strips there, but the incisions were less than 1/4 of an inch. And that is something that patients are really very pleased with when they just want to be able to wear a shoe. This patient does not have diabetes, but he does have a type of neuropathy and some other neurologic pathology with Parkinson's and actually Lewy body disease. He was unable to walk because of this plantar tyloma. You can see how really macerated and painful, in spite of the fact that he was using a donut cushion to keep that off of the ground. This is at the 10-day point. You can see I'm just about to take those steri-strips off, and that tyloma is still there, but it's everything else is sloughed, and ultimately he had complete resolution of that painful aspect. Here are my x-rays. These are the before x-rays. Quite a bit of unique Brady metatarsalgia or short metatarsal, yet he still had that lesion. Here is in the post-op. If you can see my screen, these are where the osteotomies were performed, and he went on to heal beautifully. For this particular patient, the goal was straight toes. Patient had, if you can see, looking carefully, this was a 86-year-old female. She was unable to wear a closed shoe. She had a 90-degree angulated toe. This was from a failed hammer toe procedure that had been performed. If you can see generally the incision site initially. This is just the dorsal view. This is a plantar view preoperatively. And this is in the OR. You can see my gloves are still kind of nasty, but you here, for those of you who are unfamiliar with how large those incision sites are, I personally do use sutures just because patients in my hand, if they bleed, they're more upset. And there was a soft tissue release at the first metatarsal phalangeal joint, and I did a proximal phalanx osteotomy as well as the digital correction. But you can see how nicely that toe came up, really and the patient was very pleased. I don't want to take up too much more time. I know that everybody is set to end pretty soon, but this is my story about hardware. And how can it possibly be said that using hardware is always the best? If you take a moment and see the lesion marker, which is closest to the second toe in the inner space. This was a case that was referred to me by an orthopedic surgeon. His PA had been treating a wound at the interdigital aspect for about a month, and it failed to heal. When I looked at it, it seemed to me that it was pretty darn close to that hardware. So ultimately we took the hardware out, and I'll go through the process that I did to correct the deformity. This is what his foot looked like. In our operating room, we call these summer toes. Some are going this way and some are going that way. This is how he looked, obviously on the table. Again, you can tell the glove formation, and you can see how small these incision sites are. Also, the line across the great toe that's a marker that I use while I have the C-arm when I'm doing fluoroscopy. It just keeps me straight is what it does.
Right.
And here's this post-op patient within 10 days, a week to 10 days after that procedure. Here is the x-ray of that same patient. This is the x-ray after the screw was removed. We waited for that to heal. I did do a bone biopsy, and the infectious disease doctor with the biopsy felt that antibiotics would be helpful. So we did 6 weeks of antibiotics just to make sure that ulceration did not go down that track. And then this was just immediately pre-op. Here you can see the osteotomy. I'll try to draw it out again. Hopefully you can see my screen. This is the first proximal phalanx osteotomy. I also did an osteotomy across the base of the proximal phalanx of the second and third, and the middle phalanx on the second. That's a real nice result. In fact, the patient had a similar problem on the contralateral side, which I fixed as well. And then finally, just our goals with minimally invasive surgery in the high-risk population is freedom from pain. This, as to Dr. Claywater's point, this patient had a Taylor's bunion deformity that was unfortunately not corrected, and I will show the x-rays towards the end of this. And you can see the lateral eminence. She did have a very aggressive bumpectomy, which unfortunately led to complete instability of the proximal phalanx. This is her post-op result. For those of you who can't see the incision site, neither can I. I can't tell you where I put it, but probably right about there. And that's what's so nice. So here are her pre-ops, and this gal, I did the 1 foot and then she asked me to do the other. And you can see how dislocated that fifth toe is with that previously very aggressive bumpectomy that this is her pre-op. And this is the post-op. I did not in this presentation show the final follow-up. These cases do take a while before they show radiographically healing, but she had complete resolution of pain after 6 weeks, and enough that I'll go back to that, enough that she asked me to do the other side. So in conclusion, minimally invasive surgery technique offers a much safer and less invasive surgical option for permanently alleviating painful conditions, or for those with diabetes and neuropathy, those conditions that lead to infection and amputation in the population of patients that might otherwise not be optimal for traditional procedure, and therefore would not tolerate extended periods of disability or the incision sites that go along with traditional surgery. And I have to thank Dr. Claywater for setting up how perfectly her patient's case description was for this. I thank you all very, very much. I just, my mentor, I have to give him the thanks, and that's Boots Horowitz. And thank you everyone for taking the time to hear what I had to say this evening.
Beautiful.
Thank you. I don't know how to get out of this, guys. So somebody else stop share. There, I got out. Yay. If anyone has any questions, I'm certainly I'm willing to take them, but I do feel like this is a little bit of a primer for it's across the professional and the population that I use this PowerPoint.
Dr. Charles Perry wants to know, did you force over the 5th med head, or would it move over by itself?
When I do that osteotomy, the metatarsal aligns, when I move the metatarsal head, the proximal phalanx of the 5th toe aligns perfectly. It's kind of like the same, not kind of like, it's very much the same philosophy as a cross toe deformity. When you have an elongated second metatarsal, the same concept with a Weil osteotomy.
Yeah, that was an excellent result. I know we have all worked in the lab together, and what you also, we want to mention that you do, both you and Dr. Claywater do office-based surgery. So when people are having healthcare issues here or wherever they are, and it costs an additional $5,000 to $10,000 just to go into a surgical center and rent the room for that hour. So you offer not only an excellent correction, but a big savings to the patients when they will just pay for the procedure and not have to pay the thousands of dollars associated with surgical center fees or hospital fees. Hospital fees, I know 30 years ago, they were getting paid upwards to $25,000 per hour at a hospital just to do a bunion, for example. So the minimally invasive techniques, I know Dr. Dana Tate, she's on the Zoom tonight. She does minimally invasive surgery. And so it's always good to do minimally invasive surgery for everyone, but especially those who are geriatric, as you said, those who have vascular issues and skin conditions. So you can take a little bit more risk because it's a smaller incision and you can help the patient drastically with minimally invasive surgery. Well, tonight, it's 8 o'clock, and we want to thank those who have joined us this evening and those who have taken the time out. We will have a recording available. I did have some emails that people had sent me last time, and those emails got kicked out for some reason. So whatever that was all about. Can you see my screen sharing now?
Yes.
Okay. This is just 3 little slides. I know it's 8 o'clock, 8:05. These are some of the emails, this one and this one. I'll go back. But these are some of the emails that I got out of the chat room last time that were kicked back out for whatever reason. And so maybe I put them in wrong, but if you see your email address, please try to reach out to us through caribbean.dfu.mis@gmail.com, and we'll be able to get the email correct and get you on the invitation list. Also, I will not be giving a lecture tonight. I'll spare everyone because it's pushing 8 o'clock or 8:06. And unless there are any final questions for any of our guests, Dr. Beth Claywetter, the president of the Academy, or Dr. Beth Pierce, the vice president, and Dr. Richard Mann, we appreciate you coming and discussing how we can repair nerve damage and polyneuropathies in the diabetic foot. And so without further ado, we'll just go ahead and bring this meeting to a close. And Tiffany, were there any other chats that you see? I see Dr. Dorsett. She's a medical doctor here, and she's taking the time out to visit us at Foot Neck International to pick up on a lot of techniques. I heard Dr. Pierce talking about the referral from the orthopedic surgeon. So what I have seen in the past 20 years is that the orthopedic community, the medical community, and podiatry have now teamed up. And by teaming up, we're able to grant the patient the best results because the medical doctors will keep an eye on their hemoglobin A1C, their random blood glucose, their hypertension issues, and any other issues. And when all of that is addressed, the diabetic ulcers are healing and the limbs are being saved. All right, I see a couple emails. Loving Hands, Podiatry 55. I'll get a record. I'll make note of that and put you on the invitation list. And just wanted to say thank you to everyone who did take time out of their busy schedule to join us this evening. Thank you to our lecturers. And Tiffany, any final words from your end? And H2K Canada, our sponsor, who's with the wonderful products of Diabesoft and Boratotal.
Hi,
Yeah.
once again, Dr. Horsley. Thank you so much. And on behalf of Health 2000 Canada, great presentations, everyone. Thank you so much for the services that you do. It is much appreciated. And as you know, with H2K Canada, one of the things that we do believe in is foot care. And that is a lot. Well, we find here in the Bahamas, a lot of people don't really know anything about maintaining their feet. And when they go to the clinics or the hospitals, a lot of times, and no fault of their own with the GPs, they are so busy, they don't have time to check their feet. So H2K has bought on the Diabasoft, which I'm sure many of you might be familiar with. It contains coconut and sesame oil. And what you do is you use it every day on your feet. And it helps to keep the feet soft and supple because you avoid between the toes. And we absolutely love it because if, like a lot of times you see people come into you and it starts out with dry, cracked feet. And eventually those feet, the cracks get deeper and they turn into cuts. And the diabetics, because of the lack of feeling down there, a lot of times they don't feel anything. So doing this every day and using the Diabasoft, it gives them an opportunity to check their feet properly. And then there is also the Boratotal Neem Cream that has neem and aloe. Therefore, they have healing properties. So that's another one that we recommend for our diabetics when they have little cuts and bruises and bumps. You can just take it and rub it in. So we recommend that you use one in the morning and one in the evening. Alrighty, so that is me. Thank you once again, everyone, and have a great evening. Back to you, Dr. Horsley.
Okay, well, I just want to say, I know Boratotal works because I had a rash starting on my ear from the mask that we still wear here in the Bahamas. And I kept noticing it and I said, well, let me put some of this Boratotal on here and maybe try that for a week, see if it works. It worked overnight. So I don't know if you want products working that quickly because that means they're working too good.
Yes, it is an awesome product. My daughter swears by it.
I can't believe it. I forgot the rash was even there. So thank you, H2K. Thank you, Dr. Mann with the remedy. And that's it for this evening, everyone. Appreciate you staying a little overtime. And hopefully you'll join us June 29th for our next series in lower extremity amputation prevention. All right, thanks again and have a good night. Enjoy your dinner or your late night drink.
Bye, everybody.
Okay, bye-bye.
Bye, everyone. Thank you again.
All right.
Yeah.
Private